Now start. So good evening, everybody. I'm very pleased. I'm Francisco Sanguedolce from Barcelona. I'm the chair of the section of EAU Immunological Imaging. And it is our pleasure because today we are going to share this webinar with also the section of the EAU in research, represented by Professor Kristen Taskin. Please, Kristen, Kristen, she's a brilliant an expert in cancer research biomarkers from University of Oslo in Norway, and she also is a board member of the ISU section, and also since a few months she's been also appointed as ex officio member of the ISU section. So this is an honor, obviously, to share with you the podium tonight with these distinguished colleagues. We are going to talk about what's the new things that are happening in prostate cancer in the hormone-sensitive setting, from the molecular environment to the molecular imaging to ending up on theranostics. Please, Christine.
Yes, so good evening, everybody, and welcome to this UROWebinar entitled From Molecular Environment to Theranostics in Hormone-Sensitive Prostate Cancer. So today we will have three speakers with us. This will be Johan Lindberg, who will present the PROBIO trial, Daniela Oprea-Lager, who will tell us about the PSA by PET and other further radioligands, and also Douglas Scher, who will tell us about theranostics in hormone-sensitive prostate cancer, the new frontiers. So the treatment landscape for metastatic hormone-sensitive prostate cancer has rapidly evolved the last years, emphasizing a transition towards the use of new imaging modalities, combination systemic therapies, and theranostics. And this advance of more effective treatment for hormone-sensitive prostate cancer has been built on successful in therapy development from metastatic castration-resistant prostate cancer. So at present, we are accumulating knowledge to discern the optimal treatment modalities and the sequences and intensities of therapy for each patient, aiming to maximize the disease control and while managing treatment burden. So we are looking very much forward to hear the update from these three speakers today, representing three different areas for how to diagnose and treat these hormone-sensitive patients that we are dealing with. So a range of molecular mechanisms underlies the prostate cancer progression, as we know. However, leveraging this knowledge to inform treatment strategies is still in its infancy. But we have with us today one of the pioneers in biomarker-driven clinical trials in prostate cancer, and that is Johan Lindberg, who is one of the principal investigators for this PROBIO trial. Johan Lindberg is a principal investigator at the Department of Medical Epidemiology and Biostatistics at Karolinska Institute in Stockholm, and he's also affiliated with the SciLife Lab in Stockholm and holds a part-time position at the Molecular Cancer Diagnostics at Karolinska University Hospital. And his research teams is involved in several biomarker-driven clinical trials that are based on prospective genomic profiling. And one of these trials is the PROBIO trial. And the initial findings from the trial was presented at ESMO 2023. But today, we look forward to learn how the PROBIO platform can be utilized to inform treatment decisions in patients with hormone-sensitive prostate cancer. So now I pass the screen and the word over to Johan Lindberg.
Thank you, Christine, for that very nice introduction, and thank you for the opportunity for me to present the PROBIO trial. Now I'll share my screen. So are you seeing my screen? First, I just wanted to say that the PROBIO trial is it's a complex clinical trial, and this is not a one-man show. So to be able to run this kind of trial, complementary competences are needed. So I have a background in biotechnology, so I'm basically I'm heading the lab and also the bioinformatics unit, but I'm working really closely together with Henrik Grönberg, who is a professor at Karolinska as well, and is an oncologist, and Martin Eklund, who is a professor of biostatistics. So we went into the forest at very late of 2018 and had a discussion about starting the PROBIO trial. And that's actually when it started. And the reason why we had this discussion is that there's a lack of treatment predicted biomarkers for men with metastatic prostate cancer. So I'm very sorry, I have my dogs in the background. I hope it's like so the first thing that we asked ourselves when starting the PROBIO trial was, of course, are there any biomarkers that we can test in the trial to be able to try to find treatment predicted biomarkers? And so what I did after that is, of course, I went to the literature. I read the ICGC, the TCGA papers, and also from Stand Up to Cancer, and made a catalog of the most common drivers in metastatic prostate cancer. And then I created a panel that we are applying in the PROBIO trial to interrogate these genes. But I also, together with Henrik and Martin, went through the literature to see if we could identify any biomarkers with treatment predictive potential. And I'm just going to give you a couple of examples here. So one such biomarker is p53. So what we had learned from p53 in a publication that we published in early 2019 was that patients with p53 alterations in castrate-resistant phase, they had very poor prognosis on androgen receptor signaling inhibitors. So this was something that we wanted to sort of interrogate in the PROBIO trial to see if p53 is a biomarker that can be used to select treatment, both in the hormone-sensitive but also the castrate-resistant phase. And the hypothesis was perhaps the p53 altered patients are the ones that would preferentially be treated with a taxane over an androgen receptor signaling inhibitor. And we also looked at, of course, at the androgen receptor, because as you know, the androgen receptor is the key transcription factor in metastatic prostate cancer. And so the androgen receptor, as you know, binds to testosterone or derivatives of testosterone. And when the men are chemically castrated, then the androgen receptor will be exposed to an evolutionary pressure due to the treatment. Somatic alterations will arise in the androgen receptor as a consequence of treatment. So the androgen receptor, many different types of somatic alterations can arise in the androgen receptor. We can have genomic structural rearrangements. We can have hotspot mutations and also copper number alterations, and also activation via splice variants. And what we showed a couple of years ago was that the number of alterations in the androgen receptor correlated with the prognosis in men treated with androgen receptor signaling inhibitors. So one of the biomarkers then that we wanted to test in the trial was that if patients with that had variants in p53 and the androgen receptor, and what we're interested to identify is actually good responders. So one of the biomarker signatures, as we call it in the trial, that is patients with wild type p53 and wild type androgen receptor. We think that this is a unique population that are doing really, really well on androgen receptor signaling inhibitors. So that was just one example of like the background and the reasoning for why we are testing a certain biomarker. And then in the trial, we're also testing genes associated with DNA repair deficiency. And then we have also been testing the temporal gene fusion with the hypothesis that this will be a subset that will do a little bit better on taxanes than the non-fusion positive cases. And we're also now testing patients with PI3K alterations such as P10 homozygous loss to see if these patients are responding well to ACT inhibitors. So there were definitely biomarkers to be tested in a prospective setting for the PROBIO trial. And then the second question that we asked ourselves was, of course, is it possible to analyze the prostate cancer genome prospectively and do that in a timely manner so that we send out the reports with quick turnaround, not to delay the sort of normal clinical procedures for the patients that are treated in the hospitals that are participating in the PROVIDE trial? So, of course, in a perfect world, we would like to analyze metastatic biopsies in these men. But as you know, the majority metastasize to the bone, and it's difficult to obtain high-quality material, and the success rate is low. And actually, to be honest, there's not this kind of infrastructure present in Sweden, so this is not an option. Another option is, of course, primary biopsies, but then there's a question of representation, and also quite difficult logistics to get it to work with a quick turnover. And this is the reason why we resorted to liquid biopsies. So what we're doing in the PROVIDE trial is that we are sequencing, or we're extracting cell-free DNA from plasma. And as you know, in cancer patient, then a fraction of the cell-free DNA that comes from the cancer cells, and that is what is called circulating tumor DNA. So we're doing cell-free DNA sequencing in combination with germline DNA sequencing to identify the biomarkers that are used to randomize the patients in the PROVIDE trial. And then a question is, of course, what does circulating tumor DNA represent? So this is a set of phylogenetic trees that were published in Nature in 2015 by the rapid autopsy cohort from Hopkins. And what they showed in this cohort was that, so here you see one phylogenetic tree of this patient, A10, is that the majority of drivers are present in basically all the metastases, and they form the stem. And then you have these branches and leaves with heterogeneity between metastases. But this heterogeneity almost only resorts to genes that are exposed to the evolutionary pressure due to treatment, such as the androgen receptor. So there's limited heterogeneity between metastases. And what was showed then for circulated tumor DNA in 2022 by Alexander Wyatt and colleagues from Vancouver, where they did sequencing of multiple metastases and cell-free DNA, is that all the metastases, they will shed apoptotic DNA that will end up in plasma, which is sequenced, of course, if you enrich plasma from the patient and sequence the cell-free DNA. So the different metastases are shedding the biomaterial, and the stem that you identify in circulating tumor DNA, that is the variants that are present in the majority of metastases. And this will be the variants that are clonal in circulating tumor DNA that have really high variant allele fraction. And then the leaf and branches that you identify in circulating tumor DNA, that is the variants that are subclonal in circulating tumor DNA. What we're also using, of course, as I mentioned previously, is that I created this panel to interrogate the prostate cancer genome. I'm not going to talk about this in detail, or the bioinformatics setup in detail, or the lab setup for that matter. So if any of you are interested in hearing about how exactly we are doing this, the ctDNA profiling, just pop me an email and we can have a discussion about that offline, because otherwise this presentation will take a very long time. We have biomarkers to interrogate, and we have a setup so we can interrogate the prostate cancer genome prospectively. And then the question is, of course, which treatments should we test in the trial, and would it be possible to collaborate with pharma? So what we did when we started the trial in the castrate-resistant phase, and then it has expanded to the hormone-sensitive phase, is that we started with the drugs that were approved in the different countries that are participating in the PROVIDE trial. And then we also reached out to drug companies, but basically the interest was very low because they didn't really believe that we can establish this infrastructure. But after the trial started, then we got a lot of interest. So right now we have androgen receptor signaling inhibitors in the trial. We have taxanes, platinum, and then we have a collaboration with Janssen where we test niraparib and abiraterone in combination, both in hormone-sensitive and then also castrate-resistant phase. And then we're also testing a PI3K inhibitor in the castrate-resistant phase. But we have 2 additional drugs incoming, and both, I can't really talk about them at this stage, but both will be in the hormone-sensitive phase. And then the next question is, of course, what kind of trial design should we use for the PROBIO trial? And then I want to make an analogy to Olympic stadiums and what happens to Olympic stadiums after the Olympic Games are over. So this, to the left here, you see what happened to the swimming pool that was used for the swimming competitions after the Rio Olympics. So after 1 year, it was just left, and it's not pretty. And this is somewhat similar to what happened with normal clinical trials, where drug companies they invest a lot of money to test this one question, and then the established sort of structure around that question is not reused. But to the right here, you have the complete opposite. You have the Panathinaikos Stadium in Athens that has been that is used even today after 2,000 years for competitions. So we wanted to establish something that could be reused and to test additional hypotheses after the initial hypotheses that we posed in the trial have been answered. So therefore, we designed the PROBIO trial as a platform trial. So it's a standing infrastructure for research where we can add new hypotheses in the trial infrastructure. And we're also using something that is called adaptive randomization. I will get back to that. And we also have a common control arm to increase efficiency. So this is the trial setup. And this is a somewhat complicated figure, but I will walk you through it. So here, so here to the left, we have the hormone-sensitive setting. And here to the right, we have the cance-resistant setting. And a patient can enter PROBIO via 2 entry points, even as a de novo metastatic hormone-sensitive prostate cancer or as a metastatic castrate-resistant prostate cancer. But preferably, we of course prefer the patients to enter at the hormone-sensitive stage of the disease. And what happens then is that both for hormone-sensitive disease and for castrate-resistant disease, we do prospective ctDNA analysis. We actually allow for tissues in the hormone-sensitive disease, but from a practical perspective, it's very few cases that we have analyzed tissues for so far, due to the difficulty of getting the tissues out from pathology in a quick manner. After the patient is analyzed, then the patient is randomized either to the control arm or one of the experimental arms. For each experimental arm, or for all the experimental arms and for all the biomarkers that we're testing in the trial, so we call them biomarker signatures, then we have set a set of randomization probabilities. So if you have a certain biomarker, then you have a certain probability of ending up in an experimental arm. And this randomization probability, that will change over time in something we call outcome adaptive randomization. And this is an example of real data actually from the PROBIO trial. So here we have treatment A and treatment B. And from the beginning of the trial, we thought that this biomarker X would do better in treatment B. But as the outcomes data accumulate, when we know how quickly the patients with a certain biomarker signature progress, then the trial actually it's basically a self-learning system. So the patients with biomarker X were first treated with higher probability in treatment B, but actually treatment A worked better. And then the randomization probabilities are changed over time, and then the probability of a patient with biomarker X getting treatment A increases in relation to treatment B. And then we also have, of course, a connection between the hormone-sensitive phase and the castrate-resistant phase. So preferentially, a patient that enters hormone-sensitive disease will be in the trial, and then after he progresses, the patient will re-randomized in the castrate-resistant setting in the PROBIO trial. Yes, and we have a common control arm, and the patients that are in the control arm, they stay in the control arm. And then in the castrate-resistant phase, we also allow actually for patients to be re-randomized. So the perfect patients from our perspective in the PROBIO trial, that is a patient that enters the hormone-sensitive phase and then progresses to the castrate-resistant phase, and then we re-randomize the patients again. And then we have sort of maximized the information that we can learn from that patient. in the trial. Yes, and then I just wanted to comment briefly on the trial properties, basically. So this is quite a complicated trial, and the statistical properties of the trial have been evaluated through extensive simulations. So that's how we sort of have defined the properties of the trial. So basically, via simulations, we have established a framework for how we make sure that the false positive rates and so on are acceptable. And if something graduates from the trial at the predefined threshold, that is decided via interrogation or via communication with a data safety monitoring board. And the DSMB, as it is called, gives us, if we have something that has the potential to graduate from the trial, give us recommendations what to do basically in that situation. Either to terminate something that doesn't work at all, that's one option, or to graduate something that actually looks so good so that it doesn't need a validation.
Okay, so thank you so much, Johan, for this excellent overview, introduction to a very complex trial design. So I think we have to move on now, but maybe I can just ask one question before we go to the next speaker. And I think maybe if we have time, we will also have some questions at the end of this webinar. So do you think this outcome adaptive platform design is the way to go to bring precision medicine into the clinic?
I think it's actually a very effective and quick way. I mean, we have already results from the trial that are looking really, really good, that we are writing up and trying to publish from the castrate-resistant phase. And it was actually quicker than we foresaw. So we were surprised ourselves how quickly the trial engine identified biomarker signature treatment combinations that graduated in relation to standard of care. So it's actually it beats standard of care.
Exactly.
So just to summarize,
I think I will give the word back to Francesco.
Yes. So thank you very much, Johan. It was really an interesting presentation. So because it's very important for the audience to understand or to know what is in the background, and because most of current, as you highlighted, treatment or radioligand tracers that we're using nowadays is basically the product of your research. So in terms of, just to summarize a little bit, you are basically suggesting that in one of the main area that you're working on is basically to identify those patients that might be more suitable for this or the other treatment, so to predict basically what is the best. So not just, for example, a patient that because of the charted criteria might be suitable for doublet, duplets, or triplet, or whatsoever treatment, but to adjust it according to other factors that are the biomarker predictive of treatment. Is that correct?
Yes, that is completely correct. I mean, of course, other factors also come into play, such as, tumor burden and so on. But that's something that we're looking into in the context of biomarkers. And we know for retrospective research that there's a lot of heterogeneity between how the patients respond, right? And there are strong retrospective research results showing that some of the genes could preferentially, or patients with alterations in certain genes would preferentially be treated with a certain treatment. And that's what we're testing prospectively in the trial.
Very interesting. So obviously, for anybody who is listening and watching this webinar, there's the possibility to directly address the question that we obviously will comment on during the rest of the webinar. So feel free basically to type your questions, and we'll bring in for discussion during the rest of the talks. So thank you, Johan. Obviously, stay with us because I have other questions also. Hopefully, we'll have the time to go through also these and further ones. And I had to move on, and it's my extreme pleasure because I have to introduce you a special person. He's Professor Daniela Oprea, especially because obviously he's a brilliant physician. She's a professor of nuclear medicine in Amsterdam. Also, I had the honor to be a friend of her, or at least to feel like to be a friend of her. And she's one of the prominent European and worldwide class a renowned medical nuclear medicine physician. She's a member of the guidelines, EU guidelines in prostate cancer, and she also recently joined us in the board of the ESWI board. So, and today what we wanted her to talk about is basically to shed some lights on what actually means PSMA PET. And because everybody knows what is PSMA PET, but there are many things actually are more the things that people don't know than those that actually are urologists are aware of, especially urologists. So we asked Daniela to give us an overview of what PSMA as a class test may involve, and then eventually give some hints about what actually would be beyond that, this radioligand, where there are actually furthermore in the pipeline. Thank you, Daniela, and the screen is yours.
Thank you very much, Francesco, for this kind invitation. Good evening, ladies and gentlemen. It is a privilege for me to discuss with you today about my favorite topic, PSMA PET and other radioligands. These are my disclosures. As you can see, I'm still a young doctor, but I think the most important disclosure that I have, and it was a surprise of the afternoon, was this sample of finest selection of chocolates that I got from the students for being an inspirational teacher. So I hope today also to be able to provide an inspirational talk, and I will focus on the PSMA PET tracers, the indications of PSMA in clinical practice. I shall also discuss the new kids on the block, the newcomers, the FAPI PET, in a very short way. And of course, at the end, I shall draw the conclusions. So talking about PSMA, we know it's a type 2 transmembrane protein, a promising and specific target for prostate cancer imaging. It is indeed overexpressed in prostate cancer, up to 1,000-fold on nearly all prostate cancer cells. Also, we know from the literature that up to 5 to 10% from the prostate cancer may have no PSMA expression, so they are simply negative. PSMA represents an excellent target for diagnosis and therapy, creating that magic theranostic concept. And what is more important is that the PSMA expression correlates with unfavorable prognostic factors. The higher the Gleason score, the higher the T stage, the higher the PSMA expression that we'll see on the PSMA PET scans. The PSMA PET tracers, already from 2017, we had a couple of them, and I think we can, by and large, divide them into two main categories. On one hand, the gallium-68 labeled PSMA tracers, and on the other hand, the 18F PSMA radio-labeled tracers. And actually, they have somehow a comparable biodistribution, with one exception that you can see on the right side, the 18F PSMA 1007 being primarily hepatobiliary excreted, while all the others are renally excreted. But the main differences between these two categories are, on the first place, the fact that the gallium labeled PSMA tracers are generator products. So you can buy a generator in your own hospital and can produce for a couple of patients per day, 3, 4, 5 productions maximum, while the 18F products are cyclotron products. You can produce it on a large scale in a cyclotron, and then we are able to distribute to some other centers, which might be potentially also a financial benefit. Then the second difference is that the half-life time of gallium products is 68 minutes, while the 18F has 110 minutes. So it offers some more space to distribute to other centers not having a cyclotron on their basement. And the third and the main important difference between these two products is that the 18F have a shorter positron range, which allow us to have a better image resolution, which allow us to better visualize the small metastatic deposits. Now, talking about the biodistribution, with one exception, the hepatobiliary excretion in 18F PSMA 1007, we see that there is always physiological uptake in the lacrimal and in the salivary glands. We also have some variable uptake into the liver and the spleen of the patient, with the majority of the tracers being excreted via the kidneys to the ureters and the urinary bladder. And of course, I can imagine that you will ask me, what about the urinary excretion? Because this will impair us to better judge the prostate bed in the biochemical relapse, or to better judge the presence of the tumor in the prostate at the initial staging. But I will show you a couple of examples. And of course, we can always use some Lasix, some diuretics in order to eliminate this urinary impediment in the urinary bladder. What are the main indications for using PSMA PET in clinical practice? The most two recognized indications recognized in the European guidelines for prostate cancer are definitely the primary staging and the restaging, the biochemical relapse of prostate cancer. And nowadays, we are increasingly used these PSMA PET tracers also to monitor the response to different types of therapies and to select the ideal candidates for radioligand therapy, which is also a very important element. For the sake of the time, I will focus only on the first two indications, primary and restaging. So for the primary staging, already a couple of years ago, a very nice systematic review and meta-analysis was published, including more than 300 patients, all of them being at high-risk prostate cancer. And we saw a very interesting phenomenon, namely that the specificity of the gallium PSMA PET tracer was really high, exceeding 90%, but the sensitivity showed a variable range between 33 to 99%, which is something that we really need to take into consideration when we talk about PSMA PET in the initial staging of prostate cancer. And please allow me to show this example, because what do we want as imagers to see when examining these patients for primary staging? Ideally, we only want to see the high PSMA expression in the prostate of the patient, and I would love to not have any local, regional, or distant metastases. It is our duty as nuclear medicine doctors to educate the new generations in order to report correctly the finding that we have on the PSMA PET, where it's localized, how many foci, is it extracapsular spread or not, is it invasion of the seminal vesicles or not, all these elements that are quite essential for our friends from urology in order to take the good decision on to operate or not, and also the radiotherapy colleagues to irradiate or not. But this is not always the case, unfortunately, because very often we see this kind of images, and please allow me to show you this example, where we definitely see the PSMA expression into the prostate of the patient, but we see many other foci with variable PSMA expression, some of them being compatible with bone metastasis, some of them being compatible with lymph node metastasis. And what is also important is to take a look at the substrate that we can find on the CT. The anatomical substrate of the most of the foci located in the bones can correspond with really tiny, small sclerotic lesions. And sometimes we don't even have a substrate on the CT, which really complicates the things even more. And the same is for the lymph nodes, where we radiologically are learned to call it metastasis only when their diameter exceed 1 centimeter. And like in this case, we see that the foci with high uptake are actually compatible with tiny 2 to 3 millimeter lymph node metastases. And we really need to convince our colleagues these are lymph node metastases indeed. What about the restaging? Well, in the restaging, we also had a couple of interesting studies, and this systematic review and meta-analysis from Marlon Pereira and colleagues showed us that the PSA level is really correlated to the PET PSMA positivity. In other words, the chance that we'll find a positive PSMA PET is depending on the value of the prostate-specific antigen. So you see the higher the PSA level, the higher the PET PSMA positivity. And it's also incredible when we take a look that for a PSA of 0.2, we are already having a PET positivity of 42%. Just think about a couple of years ago when we only had choline, when we only had FDG and no other tracers. This was really impossible to get with other tracers. And then when we have a low PSA value, especially in the setting after radical prostatectomy, we know the expectations are high that we probably might deal here with a local relapse. And please take a look at these fused PET-CT images in which we can see directly dorsally from the urinary bladder on the right side, a focus with PSMA expression separate for the urinary bladder. And we can also see it here on the PET images, but especially with an anatomical substrate on the CT. So when we have something like this, we really think we can help our colleagues in taking the good decision. For instance, this patient might be a candidate for stereotactic salvage radiation therapy with probably a boost on the anatomical substrate that we see in the prostate bed. But is this always the case? No, unfortunately, no, because we sometimes see this kind of images also in the biochemical relapse. And please, this is a case from our clinic in which we perform initially conventional imaging just because we were used with conventional imaging, restaging with bone scans and CT scans. And on the bone scan, I would say, yes, there are probably two bone metastases, one in the lumbar spine and one in the left os ilium, as we can see here in the sacroiliacal region. But when we perform in the same patient a PSMA PET just 1 week after the bone scan, we can see that there are many other metastatic deposits distributed in the axial skeleton, as you can see here, and the majority of them having sclerotic lesions as substrate on the CT. So yes, probably we will induce upstaging of the patient just because of this PSMA PET, but I think it's important to recognize it from the very beginning. So having said this, what is about the advantage of using one tracer, for instance, PSMA 1007 being hepatobiliary excreted versus renally excreted gallium PSMA tracer. You can see here an example from our colleagues from Germany, in which on the right side you see the PSMA 1007 with no urinary excretion, so very easily finding the local relapse. And you can see on the gallium PSMA, it seems to be something just beyond the prostate, but it takes some I should say, lessons and some scans to learn on how to interpret. I think also on a gallium PSMA and on a renally excreted tracer, we can recognize the relapse, but it might take in unexperienced hands some more time to discuss and to find it. And now let's move to the new kids on the block, the FAPI-PET. I think it's a new tracer. Everybody has about FAPI-PET. We really need to understand that cancer cells are not alone, that together with some other cell types, they will form the cancer-associated fibroblasts and the extracellular matrix. It's important to realize that these CAFs are responsible for the survival and proliferation of the cells, of the cancer cells. And the question is, what about the FAPI and the prostate cancer? Well, the FAPI, the fibroblast activation protein inhibitors, they work and they are active on the cancer-activated fibroblast via the FAP. And just like in the PSMA, we can make this radioactive and we can use it for imaging purposes, but we can also link them to alpha or beta particle and use it for therapeutic purposes. And yes, I think the FAPI-PET is also important because it has a high target affinity, a high selectivity, and also a high tumor penetration. So this is also important when we will treat the patients with this. And it seems like it might be in the future be very useful for a variety of some other cancers, also including prostate cancer, like we can see in this example. what we really need to think about when we talk about FAPI is that FAPI is also present in some other benign findings, like you can see in the bone degeneration, in the muscles of the patients, in the wound healing processes, and in female patients, we can see it also physiologically in the endometrium and mammary glands. So we really need to think about these pitfalls and common findings to learn about them. And with this, I'd like to come to the conclusions. Very shortly, I described the various types of PSMA PET tracers that have a pivotal role in prostate cancer. I discussed the indications for staging and restaging, but of course, we know it can be also useful for the radioligand therapy selection of the patients. There are new kits on the block. I think FAPI will be the next generation tracer that will allow us to learn more about prostate cancer. And I think it's more important to focus also on the theranostic concept in prostate cancer, which is quite the future in nuclear medicine. With this, I would like to thank you for your attention and happy to take any questions you have. Thank you.
Brilliant, as expected. Daniela, thank you very much. Just to remind the audience, they also will hold the during the next EAU meeting a PSMA PET course. So for people that would like also to go more through these details, they will have also perfect chance to attending the course, which is scheduled on Friday, the 4th, I guess, of and with Daniela also involved as well. So any question? Yes, there was a question from the audience, asking what do you think about using PSMA PET in primary staging? You already mentioned about that. When all the studies we have about treatment rely on CT and bone scans, so this is basically the usual questions about the current. It is actually very important question answered one: how to adapt basically the evidence we have in treatment decision making, which is based on conventional imaging, with the findings on the next generation imaging.
It is absolutely a very good question, because I have to say, nowadays we already know that PSMA PET is superior to conventional imaging. So the discussion is already done. It was demonstrated by the Australian colleagues in the Pro-PSMA trial. So we know that indeed PSMA PET is more sensitive and is more specific than the bone scan and the CT scan. And indeed, we still need to find a way to translate our findings from conventional imaging to the PSMA PET in order to interpret the high volume and the low volume on PSMA will be different from conventional imaging. But probably the discussion in the future will be more to differentiate between oligo and polymetastatic. I'm not worried about the high and the low volume right now, but it is about oligo and polymetastatic disease. It is about giving systemic therapy or still trying to do something locally to postpone or to delay the start of systemic therapy. This is from a nuclear medicine physician perspective.
I don't know whether Doug would like to add something, or Kristen or Johan would like to make some questions to Daniela as well. And there are obviously some queries that are from the research point of view, whether there are also some phenotype biomarker that can, you're working on the future to become another radioligand or future radioligand for diagnostic, for molecular imaging purposes.
For a very long time, I was hoping that the nuclear medicine community will stop developing new tracers and will go for the best one, to choose one, and that's the only. Unfortunately, it's not the case. The number of PSMA tracers is increasingly going higher. So I also see the question if we prefer gallium or fluoride-based scans just because it will be better or sharper. My preference is definitely to use an 18F product just because of the shorter positron range, just because of the quality and the resolution of the image, in which small metastatic deposits of 2 millimeters, 3 millimeters can perfectly be identified, which is not the case on the gallium PSMA tracer. Yeah.
Interesting. Christine, you have any question or any comment?
Yes. Do you see that PSMA PET will be an option for everybody in the staging phase before surgery in the future?
I think it's very important to wisely use the PSMA PET, and nowadays we recognize the use for staging of patients at high risk, having high risk prostate cancer, so not in low risk and not in intermediate risk with a good profile, because in that case the chance that we'll have a positive PSMA PET scan is quite low. So I wouldn't recommend it. High risk, it is another story. Yes.
So do you think we need some nomograms or biomarkers to identify whom to do the PSMA PET on?
Absolutely, it's very important. We also perform a couple of trials in which we try to implement the PSMA PET into the nomograms, and we see that the effect of selecting patients also introducing the imaging component in this nomogram is really essential and will help us to guide which patient will be the ideal candidate for prostatectomy.
Okay.
Very good. So there was just one thing. So are we expecting some changes in the next EU guidelines edition? Because obviously PSMA PET still is warned not to be used in the current practice unless, it needs to be tailored according to the circumstances. There's a big warning about be careful when you use it, because we don't know whether, the data and the outcomes you really are in support of it. So how would you?
I would love to give an answer, but I think it's better to wait until the 7th of April, because on the 7th of April, we have our guideline presentation, and the new guidelines will be presented and all the changes we've performed. So I would have 2-3 weeks of patience.
Okay.
Sure.
We have to wait.
Yes, it was the last question, but I mean, it's easy to answer. Is about whether gallium fluoride, there's anyone better, there's any real difference. You've already been going through the differences. One thing that probably a message we should deliver is that each one may have some pitfalls or some issues regarding eventual risk of false positive or issues regarding the interpretations, and this needs to be typical for each tracer, needs to be known from the reader.
We try to have a way in which we interpret the PSMA PET tracers, which is applicable for every tracer. So probably for PSMA 1007, there is only the uptake, which is higher in the liver. Then we have to take the spleen as a reference. But for all other criteria, we can use just the same way to interpret the images. And I see a last question, if I think that lutetium PSMA will be used in an earlier stage of the disease, yes, I definitely think that this will be the future and that we should demonstrate. But I don't want to talk in the name of Professor Scher, so I will leave this to the other experts. Thank you so much.
Yeah, actually, it's a perfect introduction to the next speaker. And also in this case, I have the luck to introduce also a friend. I have the honor to meet some months ago in Salzburg. Professor Doug Scare is a prominent urologist from Weill Cornell in New York. He's one of the co-director of the Weill Cornell Masterclass in Salzburg, which is something that also to the audience I recommend, especially for the youngsters, the young ones, to have the chance to apply for, because he's a full immersion urology, very intense and with high-level speakers. And Doug was at that time, providing and the audience with excellent presentation, also great interactions, also in the time of the lectures. And so I'm very happy to have here today. He's directly from New York, connected from there. So he will give us actually some hints of what is happening for the theranostic in hormone-sensitive prostate cancer. We have some data, the Vision trial and TRAP trials already published in castration-resistant, but it's interesting to see whether there will be any future in the hormone-sensitive setting. Thank you very much, Doug, Professor Scare, to be with us.
Thank you, Francesco. I appreciate that. Can you see my slides okay? Okay. So we just heard a beautiful talk on the diagnostics of PSMA imaging. And now I just want to transition into more of the therapeutic components, because I think the two are very much go hand in hand. I have no conflicts to report for this talk. So PSMA, as we've been hearing about all evening, has really revolutionized imaging for prostate cancer. And we're living through a really exciting time in both the imaging perspective, but also it's beginning to evolve into a therapeutic changes as well. And it's really moving the needle and changing the treatment paradigms. And I think PSMA targeting, has become, I shouldn't say will become, but really has become the cornerstone of imaging for prostate cancer. And I will argue is really quickly becoming one of the cornerstones of treating prostate cancer. And I wanted to get into some of that today. So we've seen this evolution, and, I've been doing this now for 40 years, and we've really seen, a change from just simple X-ray and IVP imaging to ultrasound to scans, and now really molecular imaging has taken over the field, and I would argue for the better. And I won't go into all the different PET agents because we've just had a nice talk on that, but suffice it to say, there's many agents ongoing and there's many more to come. So I think this will be a very quickly evolving and transformative field. And I think what we heard about a little bit in the last talk is the classifications or the stages by which this is happening has really been pushed to the left. We're really seeing a much earlier application, certainly of imaging. And, we've seen in terms of PSMA targeting, we're seeing a transition as well. We've been limited for many years to the castrate-resistant prostate cancer arm, but we're now beginning to move the needle towards, hormone-sensitive prostate cancer. And ultimately, I think we will even go further. We're going to begin to look at some high-risk localized prostate cancer, and we'll get into that a little bit later in the talk. If we look at radiation for oligometastatic sites of prostate cancer, one of the key aspects of radiating or having, metastasis-directed therapy is to understand where are the sites of disease. And I think what PSMA has really done is enable us to better identify, better identify the sites of disease. And what we see when we look at metastasis-directed therapy and add PSMA into the mix, we're seeing a significant divergence of progression-free survival and disease-free survival in these diseases, simply because we're better able to see these metastatic sites in oligometastatic disease, and a result, better able to target them with radiation therapy. So what is PSMA TRT, or prostate-specific membrane antigen targeted radiotherapy? And this is the key here. It's essentially administering IV radiation, which ultimately tracks and ends up in PSMA positive cells. And the radionuclide is the radioactive particle. And for the most part, these have been beta or alpha emitters, and we'll talk a little about the differences in a moment. And the efficacy of these treatment paradigms and both the toxicity are in direct relation to the particle and the radioligand that's utilized. Aside from the radionuclide, I think the PSMA targeting vehicles are a critical aspect to both imaging and therapy, because these have different properties, mostly related to the size of the vehicle, and this affects both the kinetics and the biodistribution of these treatments. So different examples, there's been a whole slew of PSMA TRT trials. This is just a few to mention, and there's been many. The ones with the bold red arrows are ones that we've initiated at our institution, predominantly involving lutetium and actinium as beta and alpha emitters, respectively. And there's been many other trials we've been involved in. The ones in bold are actually phase 3 trials. And so this is, these are all for castrate-resistant prostate cancer. But there's, suffice to say, this has been a robust field, and not only in our centers, but centers throughout the world are really adapting to these trials. And the FDA now has approved lutetium as a treatment for metastatic castrate-resistant prostate cancer. So this is no longer investigational. These are really becoming standard of care. So in looking at the monoclonal antibody versus the small molecule ligand, these are important things to understand from an imaging and a therapeutic standpoint. Monoclonal antibodies tend to be much larger, with molecular weights of about 150,000, as compared to small molecules or ligands, which have a much slower molecular weight. The antibodies, because of their size, have a much longer circulation time. And this has implications because imaging needs to occur really 3 to 8 days after injection, as opposed to small molecules, which you can get optimal imaging within hours of treatment. Monoclonal antibodies are mostly delivered through the vasculature, as opposed to small proteins and ligands, which can rapidly diffuse into sites of PSMA expression. And this relates to toxicity we'll speak a little about in a moment, based on the size of these molecules. So in terms of the actual radioligands, both alpha and beta particles, these also have significant differences that play into treatment and how they're delivered. Alpha particles, as you can see here, are much larger with a relative particle mass of about 7,300 compared to beta particles, which are much smaller. The initial energy per particle for alpha particles is much higher, of 3 to 8, versus a much lower beta particle delivery. The ranges vary. And importantly, the last column, the DNA hit to kill cells, we see are very different. So these are important things to understand in delivering therapy and also implicate toxicity and side effects. So if we look at our own experience in this area, and this is really looking at the large versus small key targeting in terms of differences in side effect profile, we see patients who have been treated here for either lutetium delivered through a monoclonal antibody or lutetium delivered through a small key or small particle ligand. We see that the antibody delivered effects affect bone marrow. And you can see neutropenia, anemia, and thrombocytopenia are much higher when using a monoclonal antibody, as opposed to small molecules. They have more PSMA positive off-tumor effects, where we see effects to the salivary gland and GI tracts, giving you xerostomia and nausea as side effects. So it's important to understand these. Interestingly, we began to look at potentially combining alpha and beta particles. And so this is a trial we did here looking at combining both lutetium and actinium. And we saw the most significant, this was a phase 1-2 trial where we saw the most significant reduction in tumor volume was actually with the combination of both particles to get the best response from a tumor perspective. And obviously this carries with it different side effect profiles, but I think ultimately the future may lie in combining some of these alpha and beta particles to get maximal efficacy. So we've spoken a little about the castrate resistant state, but what about the hormone sensitive state? So we spoke that we're now going to be looking into this area, and I would argue this is probably the newest kid on the block in that we don't have any real mature therapy or data to support this yet. Having said that, we do have some very active and robust clinical trials that are examining this very issue. And so the real question is, can it be used in this state with equal efficacy as we see in the castrate-resistant state? And, you know, we heard about earlier that PSMA expression goes up as prostate cancer navigates to the hormone-insensitive state. So the question is there enough or adequate PSMA activity in the hormone-sensitive state to give some similar responses? And these are the things that we're beginning to look at. And interesting, we spoke a little bit about earlier metastasis-directed therapy. I think there's compelling data now to show that targeting metastatic sites has efficacy in long-term survival. And the question is, can we combine metastasis-directed therapy with some form of anti-PSMA-directed therapy to improve the efficacy of the radiation, but also perhaps to diminish the toxicity of the radiation by using lower doses? And these are some of the questions we've spoken about. 2 trials that are waiting to mature is the lutectomy trial. And the lutectomy trial is delivering a lutetium-based PSMA therapy in a post-prostatectomy high-risk patient. And this was a trial that we're waiting on data. It's completed accrual now, and I suspect in the next year or 2, we're going to start to see some data from that. And then there's also the upfront PSMA trial, which is a docetaxel combined therapy looking at PSMA-targeted lutetium therapy in conjunction with docetaxel versus docetaxel alone in patients who have hormone-sensitive early metastatic prostate cancer. And so these are 2 trials that we're waiting on some data that will be maturing soon, and so I wait with excitement to see what role this is going to have. We spoke a little earlier about dose-adapted stereotactic body radiation, or SBRT, and this is exactly what we were describing, is if we combine a lutetium-based PSMA therapy with metastatic directed radiation therapy, we see that we can actually alter the doses of radiation therapy, and in doing so, potentially diminish the side effects. And this is a really exciting space that I think we're going to be hearing more and more of. And this is really some of the data coming out of the LUNAR trial. The LUNAR trial is a phase 2 study of lutetium, PSMA, neoadjuvant setting to ablative radiotherapy for patients with oligometastatic prostate cancer. This is a single institution trial being done at UCLA. And essentially, it's looking at prior to giving SBRT, giving a neoadjuvant dose of lutetium-based PSMA targeted therapy. And again, we don't have any data on this yet, but I think we wait in excitement to see what this will show in the ability of using this in the neoadjuvant setting to radiation therapy for metastasis-directed therapy. Another trial that we're waiting on data on now as well is the PSM addition trial. This is a phase 3 trial to compare the treatment of this lutetium small molecule directed therapy as a plus standard of care versus standard of care alone. And this is a international trial that I believe has completed recruitment, and we're now waiting to hear the results of this. Again, an example of moving PSMA-directed therapy to a much earlier state of disease in a hormone-sensitive state. And we await the data on this. I think this will be very exciting. So in summary, I think PSMA, as we've heard about in the last 2 talks, is a clinically validated, consistent cell surface target that remains very, very relevant in the current therapeutic and theranostics era. Both antibodies and peptides can accurately target PSMA-positive cells. And as we see, they can be radio-labeled with very different kinetics and biodistribution that really needs to go into play in the side effect profile of these treatments. Prostate cancer is a radiosensitive disease, and it's very dose-dependent. So I think, can we deliver higher doses with lower toxicity? And that's something that we're currently looking at. And we can exploit the selectivity of PSMA expression to deliver higher doses of these radioactive particles to tumors with relative sparing of normal organs. It's not complete sparing. And so the question now becomes, what is the role of PSMA TRT in the hormone-sensitive state? And we spoke about some of the trials that are ongoing now. We await data. And the real question is, can we even move these to an even earlier phase of therapy in the high-risk localized state of prostate cancer? And I think the answer is we don't know. We don't know what the long-term toxicity of some of these radiation particles are in terms of potential secondary malignancies or bone marrow changes. So these are things that we need to look at on the long term, but I think this remains to be a very, very exciting state. And I think as this data matures over the next few years, we're going to learn a lot more of what the value of this is in an earlier state of disease. So thank you, and it's been a real pleasure. I do want to specifically thank one of my colleagues, Dr. Scott Tagawa, who leads our PSMA program here at Weill Cornell, and he's been very influential in this space, many of whom you know Scott very well. So thank you.
Very good, Doug. Thank you very much. Kristen, obviously I want you to come on board and for this last leg of the moderation of this very nice webinar. You're learning a lot. I specifically, first and foremost, there's obviously the chance for those who connected or lost some of part of the webinar to then review it, because it's been recorded and it will be soon be available also for be reviewed in on demand. I can't see any specific question, but I have one for you. Is about, according to what the trials that you mentioned, so basically theranostics in the hormone-sensitive is going to be trialed or before, for example, lutectomy, prostatectomy in high-risk patients. Then on the other hand, we got the metastatic patients, probably the de novo one, I guess. And what about for the recurrent after local treatment? Specifically because PSMA is probably the test of election. That is actually the perfect test for patients recurring after primary treatment, in a way to delay eventually long-term hormones, or delay, so having the theranostics as an option to delay further lines in the hormone setting.
Yeah, I think that's absolutely a space that needs to be looked at. I mean, quality of life in prostate cancer is a very important issue, and delaying hormone therapy, even if it's not moving survival, is a very important characteristic of treating these patients, particularly in that state. You know, post-prostatectomy PSA recurrence is probably one of the largest spaces in this area. And the question is, can this, you know, as we've heard about in Daniela's talk, I think the sensitivity and specificity, particularly the sensitivity of PSMA imaging, has really improved to the point where we're now picking up lesions, you know, with a PSA of 0.2. And I think the real question is, can we deliver to those patients, or should we be delivering to those patients, you know, radiation therapy in the form of PSMA delivered isotopes? And the answer is, I don't know. I do think it will have efficacy. The question is the safety. Does the safety outweigh the benefit in patients with such low volume disease? And that's the questions that we're waiting on. And I'd love to hear Daniela's input on this as well.
Thank you so much. I have to say that in Amsterdam and Nijmegen, so in the Netherlands, we are currently performing a trial in hormone-sensitive patients being oligometastatic, so up to 5 metastases and having a low PSA value. So we try to treat these patients to postpone the start of ADT. So we treat the patients in a 1-to-1 randomization setting between getting lutetium PSMA or standard of care. And this is at the discretion of the urologist. And we give the patient 2 cycles at an interval of 6 weeks, with plus additional 2 other cycles in case that we still have some residual disease. And up to now, we still have to enroll 6 patients. And up to now, almost all the patients have reacted after the 2 or the 3 cycles of lutetium PSMA. So the results are really amazing. And that's why I think there is room to think that lutetium PSMA will be a good solution in this hormone-sensitive setting in an early phase of prostate cancer. With less adverse events, they probably have some xerostomia for 1 week or 2 weeks, and then are a reversible process. They are still able to produce saliva.
Yeah, I mean, I think, you know, as we hear more and more about focal therapy and prostate cancer, I mean, this is the ultimate form of focal therapy. I mean, there's nothing more focal than PSMA targeted therapy. And so I do think we're going to hear more about that in early states of disease. I don't think anyone's quite ready to treat PSA only disease where there's no, you know, radiologic target that's out there. I'm not sure, Danielle, if you guys are treating any PSA only disease, but certainly as you alluded to, looking at the oligometastatic state, hormone sensitive is, I think, the largest area for data that's going to be arising over the next year.
Brilliant. There's a question from Mexico, actually. Jorge Vasquez is asking, how long do we wait or should we wait after primary treatment for restaging a patient recurring with PSA biochemical recurrence? What level of, I guess, is PSA? Do you need to get a PSMA PET? Well, I think this is a question for you, Daniela, that you already addressed anyway in your presentation.
Well, in a restaging phase, up from a PSA of 0.2 after radical prostatectomy, we can already perform a PSMA PET scan. So at a very early and low PSA value. And once again, we have to keep in mind that the positivity will be around 40%. So there is still a chance that we'll miss micrometastases, but in 40% of the cases, we'll find this. And there was also another question about the PSA of 1.4. Well, in that case, then there's about 80% that we'll find a positive scan. So absolutely an indication for PSMA PET scan.
And Danielle, both for gallium and fluorine-based PET, you feel the same 0.2 cutoff?
Yes, yes. Yeah.
Very good. Christine, any question you would like to address? Or you're muted. You're muted.
Okay. So I think we are running out of time. So I think we have to end this webinar. It has been a great pleasure. Excellent speakers and very exciting topics to discuss. So I would like to thank the speakers for their outstanding presentations and all thank all for your questions and for your attendees. I would also like to thank Ilaria and Summit from the Congress Consultants for organizing this webinar. You have all done a wonderful job. So, I think we have to close the webinar now. I wish you all a wonderful evening.
Thank you very much.
Yeah, thank you very much.
Bye.
Bye-bye. Have a nice evening. Thank you.